So I just wanted to spend some time to talk about head trauma and some issues. I was actually going to start off, and I think this is very simplistic, but that in general, when we talk about any sort of traumatic brain injury, I think we talk about not only, where the blood is located, if there is blood in the head. There are closed head injuries without any blood, obviously, as well. But the frontal lobes warrant a lot of attention with head injury. All the behaviors that we see with patients who have severe traumatic brain injuries, whether it's inappropriate speech, lack of attention, lack of focus, kind of this lackadaisical, almost apathetic demeanor and personality type, we all attribute predominantly to frontal lobe injury, even in the setting of a closed head injury without any acute blood or subarachnoid hemorrhage. So this is just meant to kind of show us that and obviously reorient us to basic anatomy. The ventricles become important as well. Certainly when we think about cerebrospinal fluid diversion, we think about the ventricles of the brain, and this is just a schematic that I like. And I think if we're placing an external ventricular drain, having this in our minds in terms of the target and the goal of the catheter into the lateral ventricles and really aiming for the foramen of Monroe gives us a sense of not only the orientation, but just the interconnectedness in terms of what we're trying to achieve with the cerebrospinal fluid diversion and relieving pressure. And we'll be discussing a situation in a few slides. So this is very simplistic, but when we think about blood in the head, I think trauma oftentimes is an area that seems relatively simple or straightforward and almost tedious. And I would just say, I think if you think about the value we have in the broader society and just our ability to command value as a specialty, I think a lot of it has to do with our ability to deal with traumatic situations in a timely fashion. Not only understanding the decision-making behind whether to operate and how to manage these difficult situations, but the timeliness that we provide in terms of accessing care. And I think that can't be understated. I think oftentimes we think of trauma as sort of this knee-jerk. We see blood, we kind of know what the path is. But I think increasingly what we're finding as we study some of these conditions like subdural hematomas, that there's actually a lot of variability, and there might be different ways and different pathways that we can try to manage patients, whether or not they're surgical up front. And so I think there's a lot more to be said in terms of more research in this area and clinical research as to how we approach these problems. But this schematic basically shows us on the right-hand portion of the screen, we can see intracerebral, intraparenchymal hemorrhages within the brain parenchyma, caused often by the small vessels, as you can see here, deep in the brain oftentimes. We can also see intraventricular hemorrhages, either primary or spillover from an intracerebral or intraparenchymal hemorrhage. Subarachnoid hemorrhages in the bottom of your screen, you can see oftentimes are layering around the sulci. Subdural hemorrhage is one of our most commonly seen issues, which is obviously below the dura, typically venous bleeding, oftentimes in elderly individuals who have significant atrophy. And because they have atrophy and more space between the brain and the inner surface of the dura, they tend to have almost a fertile environment to have excessive blood accumulate. And so this is, obviously something I would say that's our bread and butter as neurosurgeons is managing patients with subdural bleeds. And epidural bleeds, blood that accumulates outside of the dura, the covering of the brain. And we typically associate this with arterial bleeding, and fractures oftentimes are associated. And, these are the kind of infamously famous bleeds that we have to monitor closely or intervene quickly, as these patients can deteriorate rapidly. So I was actually going to take a minute to talk about non-operative head trauma, because in the grand scheme of things, I think what we often see are the sequela of concussions and, quote unquote, closed head injuries. And there's lots of terminology that's synonymous with concussion, but mild traumatic brain injury, et cetera. And I think what's fascinating to me is as we learn more about even what we classify as mild traumatic brain injured patients, symptoms can last for many months, even up to a year and a half, 2 years. And I think this is an area that perhaps as we learn more, I think we'll get a lot more recognition for all the sequela that can happen. I think when we think someone's had a concussion, they haven't lost consciousness, we're apt to think that several weeks, should be fine and they should be able to get back to baseline. But as I said, I think increasingly, for those of us who follow these patients in the long term and ask questions related to some of these issues, whether it's headache, fatigue, any sort of amnesia, confusion, dizziness, and even taste or smell disturbances, these can persist for some period of time, even after the initial head injury. So you can see on the right side of your screen, we think about different types of head injury or the mechanisms of head injury. Certainly can cause blood in the head, as the left-sided image shows, acceleration, deceleration injuries, etc. All important as we think about how we will manage these patients going forward. I will also say blast injuries are particularly are newer, but particularly fascinating in terms of high impact, high velocity trauma, which may not have as many external signs as even acceleration, deceleration injuries, and may not have as many imaging findings as well. So it's trying to understand how we classify these injuries, and then also how we can proactively treat these patients. And obviously this is often seen with patients in either military exercises or who have been in active duty or in combat. Did you want me to take questions at the end or as we go along? I wasn't sure. I'll just keep going and we'll take questions at the end. And just briefly, post-concussive syndrome is, again, something I think you will see a lot, in practice. And I think it's, this is an opportunity, I think, for neurosurgeons as well, because post-concussive patients can often be managed by other specialties, physical medicine and rehab, neurology, et cetera. But I think having neurosurgical involvement is very important. Certainly you will see this with patients, and identifying what is a post-concussive symptom versus what is something more sinister is very helpful. It will guide your ability to manage, reassure patients, and also know when appropriate times are to obtain imaging or further evaluation. Now, what's important to understand, as we were talking about, is post-concussive symptoms can last for a lengthy period of time after an initial injury. So I think it's developing comfort, and this comes with, obviously seeing these patients and following them, developing a comfort for understanding what a spectrum is of normal. Patients can have persistent memory issues, cognitive issues. We often see vision, especially with tablets, iPhones, computer screens that are bright. Patients will talk about blurred vision, double vision, which, a lot of it has to do as well with the type of monitor that they might be using. So we do see that with patients who have had a quote unquote mild head injury. Now, anything concerning, that is to say, symptoms that just seem out of proportion with the initial injury or several months after, weeks after, obviously persistent vomiting, any of those are danger signs and warrant further workup, often starting with an initial head CT to make sure nothing has changed. If there is known intracranial blood, that hasn't expanded, and certainly if there isn't any sort of new issue that might have emerged after the initial event. Patients can have other issues and multiple issues. After an injury, you can see patients who have a stroke or, have an expansion of a known bleed. So I think keeping that in the back of our minds is always helpful as we see these patients. Now, I just made a point here about recovery, because again, I think even when you're talking to your family, when folks have had a head injury, mild or even moderate, sometimes severe, they might ask you, what can be done or what should be done. In general, this is what, we suggest to patients, remain well hydrated. We encourage, being safe about pain medications in general, and certainly benzodiazepines do have an effect to depress memory recovery. Alcohol, substance withdrawal can be seen with patients who have had significant trauma, and so that is also complicating recovery. With any sort of withdrawal would be complicating. We encourage sleep hygiene, and I do this, frankly, with all of my patients, just in terms of making sure not to use a tablet or even a phone close to bedtime with a bright screen, and trying to be regular and consistent in terms of sleep. There are so many issues with sleep and traumatic brain injury recovery, and I think that certainly cannot be understated. And then in terms of, return to school or work or return to sports, very controversial area, return to play, which we won't get into today, but certainly an active area in terms of research and thinking as to when it's appropriate and what appropriate clearances we can provide as clinicians to help guide patients and families. All right, so I'll just talk a little bit about the basic the major categories of injury, traumatic brain injury, and then we'll talk a little bit about general surgical approaches. I would say, an epidural, again, tends to be, we think of it as most often an arterial bleed, so something under pressure, something likely to expand rapidly, a bleed above the dura, and classically it tends to have this shape. Now, you will notice sometimes there are subdurals that seem to have a similar shape, etc. And once you see a lot of images, you, I think, develop some comfort in terms of ways to discern this. I would say in general, when you're looking at imaging, always look at it in multiple planes: sagittal, coronal, and axial. And I think that's incredibly helpful, not only from a surgical planning standpoint, but also to decipher what type of a hemorrhage it may be and help guide you and your management plan. Now, we used to think of epidurals as, emergencies across the board. Certainly, I wouldn't tell you that an epidural is something you should ignore or understate. With that said, small epidurals, we're finding as we research and also just clinically follow patients without expansion on a repeat scan, typically obtained within 2 hours, 1 hour, with a stable neurologic exam. These patients don't necessarily have to be rushed to the operating room. And in fact, again, a lot of this depends on the size and location of the hemorrhage, the hematoma. But for small hemorrhages and a patient who has an excellent neurologic exam, they can be watched clinically. We typically watch them in our intensive care unit. We do obtain, as I said, imaging, short interval imaging, typically a 2-hour scan. Pending that image, as long as there's stability, we may manage the patient with an additional scan at 6 hours or 8 hours as a delayed scan. But all epidurals don't necessarily mean a rush to the operating room. So I think that's something that I think recently that's been a shift in thinking. Skull fractures are often associated. So I think what is certainly impressive as you're on the wards and trying to make a good windows and whether there's an underlying fracture, as this is most often related. So subdural hematomas, I would say, are by far the most common traumatic brain injury that you will encounter. Very, very common. And so the important points with subdural, these are accumulations of blood underneath the dura, and typically venous bleeding. So they tend to accumulate over time. Now, you can have acute subdural hematomas. So as with everything in medicine, there's always an asterisk. But in general, they tend to be accumulating over time. Now, I would say one of our most important determining factors as to the timeliness of the operating room versus monitoring observation is midline shift. And you can see in this image the ventricles have been moved over by this accumulation of blood. And you can see the septum pellucidum has been shifted more than a centimeter. Our cutoff typically is at least, I would say, anything a centimeter and above is concerning and should be an operative candidate. Now, with that said, a rapidly accumulating hemorrhage that might only have 5 millimeters of midline shift should still warrant surgical consideration. So as with everything, there's parameters and there's the context of the patient, but I would say significant midline shift is typically categorized around a centimeter. I think as you approach a centimeter, 8 millimeters, 7 millimeters, there should be some concern from your standpoint in terms of the patient approaching surgical consideration, assuming they have a neurologic exam that's stable and full. The density of the subdural matters. So you can see on this image, it's hypodense, and there's some areas that are perhaps isodense with the brain. So similar intensity and lower signal. If we see a hyperdense subdural, we worry about an acute bleed, and that also guides us in terms of the timeliness that we might proceed to the operating room. Here, the reason I included this is when we look at mixed density subdural hematomas, as we see on the right side of your screen, when we see the speckled appearance, the brightish, the darkish, mixed density could be several things. One, it could be fresh bleeding, in the context of old blood. That is a possibility. It can also mean membrane growth, and membranes can appear bright on imaging. They can appear isodense, as in this case, and you can see that the membranes themselves are pretty diffuse and form pockets or loculations of hematoma collection. Important as we consider our approach, whether it's burr hole drainage or a craniotomy, a small craniotomy to try to disrupt and evacuate the hematoma and address the membranes. That can be very important. So I think being able to identify the images, being able to discuss what the images convey, very important skills. And especially as you're starting out, and I would say, again, on the wards, I think the key elements are midline shift, the density of the subdural. So don't worry about, it's new blood, old blood. I think that is, frankly, more editorializing, as, patient stories might be, I fell yesterday, but I have this image. I think you're the most, you convey the most information reliably if you talk about the density that you see. In this case, it's a mixed density. Now, what does that mean? Like I said, it could mean that there's new bleeding with old blood, or more likely it means that there's membranes. But instead of having to speculate as to that, you've identified it properly with a mixed density subdural causing X millimeters of midline shift, X millimeters in maximal density. So I just mentioned this because I think being able to convey information succinctly and in the most high impact way will serve you well. Because it conveys to your assessors that you have a sense of what they're looking for and what the most important relevant points are with your clinical assessment. So I mentioned bullet wounds. Now, there's also been a shift in thinking here as well, I would say. I think historically we thought of, bullet wounds, especially through and through trajectory wounds, as being fatal events and fatal as well as just not salvageable, not something that neurosurgical intervention or participation would be warranted. I think that's changed somewhat in terms of, this is a bispheric injury kind of through and through. With that said, there are populations, and there have been, a handful of case series to suggest that some patients can, survive and have some favorable level of functioning. So I say that only because I think there's kind of this perhaps traditional mentality versus what some of the more recent data suggests, and recent methods that we have to address some of the issues that patients with bullet wounds formerly had. So what do I mean by that? Well, I think if you look at the actual situation of having a high velocity, bihemispheric injury, like a bullet wound. A lot of the sequela initially have to do with the rapid brain swelling that this can cause, the shrapnel, etc. And as our thinking has evolved about how we manage shrapnel that's intracranial, how we treat with antibiotics to prevent infections, tetanus, all these things, I think those other portions of the management have helped with overall mortality. That is not to say that these are still favorable injuries, but I think if the patient's young, if the systemic injury burden is low, meaning there's not also injuries to major organs, lungs, heart, etc., and if the patient has some preoperative neurologic exam, we've seen patients who are following commands, even with an image like this, speaking. They might have other impairments, whether it's blindness, etc., but they do have an exam and an assessment. The thought being that being aggressive with these patients, consideration of early hemicraniectomies, decompressions would be warranted. Finally, wanted to mention traumatic subarachnoid hemorrhages. This is also very common. I should say it's in terms of the operative cases, subdurals are probably your most common. This is, I would say, in terms of just general being on call, your most common. Now, making sure that you can tease apart a subarachnoid hemorrhage that's aneurysmal or possibly aneurysmal versus traumatic is important. So typically the traumatic subarachnoid hemorrhages, and again, the subarachnoid space is really a layer or space below the arachnoid, theoretically, covering the brain, where the small capillaries, small vessels live. And if these rupture, oftentimes from a shear force, this can cause, kind of small areas of hemorrhage. These are often traumatic if they appear in locations that are, as this image shows, convexity, in a specific lobe, very patchy, as you can see here, just on one side, tends to be related to a trauma. And, obviously we need the history to corroborate this. Aneurysmal bleeds tend to appear in cisterns, tend to appear in locations surrounding major vessels, such as the MCA or the ACA, etc. So having a threshold for suspicion, if something looks aneurysmal, the story might be traumatic, I would say absolutely always a CT angiogram is the next step. I think we have to have that index of suspicion that a patient may have had an aneurysmal issue first and a trauma second. They might have lost consciousness or something and fallen, etc., or vice versa. But whether the chicken or the egg came first is on some level irrelevant. It's more important to be able to understand the scope of the issue, as those patients would require timely care in terms of vascular intervention. So I would say always have a threshold for suspicion. Patients can have both traumatic and aneurysmal subarachnoid hemorrhage. So if something looks unusual, obtaining additional imaging is absolutely the right next step. CT angiogram is often the next imaging modality obtained. Now, with a patient who has just a vanilla traumatic subarachnoid hemorrhage, as you see with this image on the left, we think about things like cortical irritation. Having this patient on a prophylactic and anti-epileptic is appropriate. And we've certainly seen a handful of patients who have had just patchy areas of traumatic subarachnoid hemorrhage, but might have focal seizure or focal numbness. That even this amount of blood can cause enough cortical irritation to cause symptoms. The other thing is, if a patient has diffuse traumatic subarachnoid hemorrhage, one thing to keep in the back of our mind is development of hydrocephalus. We can also see this on the vascular side. Now, it's not, I kind of mislabeled this. It's not necessarily a consequence of having a traumatic subarachnoid hemorrhage. It's more of a consequence of the initial brain injury. So I think being mindful that even with a diffuse traumatic subarachnoid hemorrhage, the thought process being a patient still warrants close monitoring and follow-up, as uncommonly a patient may in that situation, due to their overall brain swelling, etc., either develop brain swelling, cerebral edema, or hydrocephalus, something warranting intervention promptly. Now, I didn't want to get into the nitty-gritties, but this is basically, the hemicraniectomy and trauma is kind of the workhorse in terms of when we think about rapidly expanding epidural that's large, a subdural that's acute, and a bullet fragment that we're trying to relieve cerebral compression, cerebral edema. So you can see on the middle schematic, the goal is to be as wide as possible. You're trying to expose truly half the brain surface to try to alleviate pressure, evacuate blood, or provide enough space for swelling to occur, because the swelling is what is going to help the patient the most in those situations of malignant or significant cerebral edema. So you can see here, we always feel, you can see the rogered bone here, but essentially we want to go in front of the ear. You can see on the bottom right scan about a finger breadth or so. We want a burr hole there just to make sure we're at the floor of the temporal fossa. We want to make sure that the uncus is appropriately decompressed with our bony exposure. So we do want to make sure that we have a burr hole here at the low end, so that we can, once we expose this much of the cranium, that we have enough access to provide adequate decompression. Then we've all probably heard of this reverse question mark incision. I think, again, the goal is to make sure that we've covered an adequate length and width of the brain surface. And we always want to mark out the midline. So the left-sided sketch, you always want to mark out the midline from the nasion back with a big marker, and it be at least 2 finger breadths off midline. And since our fingers probably vary in size, I would say measuring 2 centimeters, 2.5, etc. Something that's safe, so that you're off the midline. And you're not placing any bridging veins and the sinus, in particular the sagittal sinus, at risk. So really, as you can see in this schematic, the goal is maximal exposure, making sure you're at the base of the temporal fossa, the floor of the temporal fossa, so that you can adequately decompress the uncus, and trying to be as safe and efficient as possible. In an emergent hemicraniectomy situation, you can see having a few burr holes is appropriate, but the goal is to try to get the patient in, decompressed, and as quickly as a time as possible. So, and the bone flap assumedly will remain off in these situations, as you're doing it in part to relieve ongoing brain swelling. So this is really the workhorse. And I would say this, again, this is a procedure that the more rapidly you can do effectively, I think overall, in terms of developing skill as a neurosurgeon, this is how you save someone's life, is the timeliness of making the decision that the patient needs surgery emergently or urgently, and 2, actually getting the bone flap off in as safe a manner as possible. So I do think there's skill involved with both of those things, and certainly cannot be understated. Now, hydrocephalus is something we see whether or not in trauma or a patient's found down, brought to us, unclear etiology of why, but they get a head CT and this is what we see. And so we're left thinking there's something about this scan. There's something about this hydrocephalus or ventriculomegaly at this point that is related to the poor exam that we see before us. So, when we're thinking about cerebrospinal fluid diversion, placing a drain into the ventricular space, obviously we want to make sure that there's no obstructive lesions, no obstructive masses that are apparent on our head CT. So typically the first step, if you see a patient found down, oftentimes unclear if there was a trauma involved or not, you see a patient like this. We actually just had a patient like this come in this past week, unclear what had happened, found down on the street, massive hydrocephalus. And next question, anything obstructive? We could not appreciate anything obstructive, so the patient had a drain placed emergently. In a lot of these situations too, you may see some amount of intraventricular blood. And so the question is always, how do you manage that? What do you do? Now, the first things first, you want to treat the hydrocephalus. You want to treat the compression that the excess cerebrospinal fluid is causing on the remaining brain tissue. Now, intraventricular hemorrhage management varies in terms of the amount of blood, the location of the blood, and whether it actually causes the drain to clot off. I won't get into the specifics of that, but I think that's something you often see. So being comfortable, I would say, communicating and understanding that kind of throws a monkey wrench into things is important. So for instance, having a plan in place, if a patient also has an intraventricular hemorrhage, being able to communicate that I would still place a drain, I'm, trying to treat hydrocephalus, understanding that if the drain should clot off, I might need to consider next steps, whether it's trying to see if something could be injected through the catheter to help dislodge the clot, or intermittent drainage. Some folks will even do lumbar drains. That's more common, not in the traumatic setting, but oftentimes with aneurysmal related CSF diversion. So I think being able to communicate that on the wards is always impressive. Just that, there's an understanding that other issues can be at play. And even if you don't have a plan in place as to how you might address every possibility, you've at least thought through that there are these potential side effects lurking. So this is just a schematic on external ventricular drain placement. And again, I think in terms of our value, placing a drain in a timely fashion can truly save someone's life. So we always look off the midline, about 12 centimeters behind the nasion. I like to go about 4.5 off the midline. So 12 behind, 4.5 across, and you double check mid-pupillary line. And then again, you want to think in your head, the ventricular system and where you're aiming. So you're aiming, they always say towards the ipsilateral medial canthus, and then also the tragus on the opposite. You want to kind of get this line in your head, the tragus here. So you're trying to basically aim, towards, it's almost posterior and, inferior, obviously. And kind of this angle and this trajectory as if you're looking down on the person's scalp. So I think having a sense in general of where the ventricular system should lie is important. Getting a sense of the tragus on either side and sort of the imaginary line you can draw between them is important as well. So the image on the right here, you can see this shows the angulation actually, I would say better. Kind of shows you want to be a little bit inwards and then posterior as well. So I'll just quickly go over the Brain Trauma Foundation guidelines. So I was going to mention the Brain Trauma Foundation guidelines are pretty accessible online, and moving forward should actually be updated largely online as well. And again, it's something I think I would say is impossible to memorize cover to cover, but the point being that they exist and they guide a lot of practice. So important to cite that and at least know that it's something to have in the mix in terms of when to make a decision to operate or to intervene. So just wanted to mention in terms of monitoring, because that's always a challenge, especially when you're on the wards, you're taking call. This is a great question to be asked in terms of, well, should this patient get a monitor? Or, if we've decided the patient's not a surgical candidate, they're a trauma patient, found down, etc. What do we do? What's our role here, and what can we provide in terms of management? So, when we think about intracranial pressure monitoring, whether it's via an external ventricular drain, whether it's via a bolt or some combination thereof, we think about monitoring in patients who have had a traumatic brain injury, defined as GCS of 8 or below, as well as an abnormal head CT. Now, if we think about an abnormal head CT, may include all of these things, contusions, swelling, etc. We do think it's indicated in severe cases, even if the patient has a normal scan, if we see a few factors, whether the patient has a very poor exam, motor posturing, certain age range, and then systolic blood pressure. So we know that 50% or so patients who develop ICP at some point in their hospitalization, typically fairly early on, may have a relatively negative scan. Now, this is also, I would take with a grain of salt, because a lot of this data, or what's been studied, is somewhat outdated with the existing scanners, because that's always evolving and improving. But I think the idea is, even if a patient comes in with a quote unquote normal head CT, no acute blood, etc., if the mechanism of injury just seems like something that's pretty severe, their exam is poor. So for instance, high-speed motor vehicle accident, a patient who's giving you a poor exam, I think your threshold of suspicion should appropriately be high in terms of potential issues to develop high ICP. So in terms of other conditions for monitoring, frankly, this is, I would say, variable and still a topic of discussion. And there are periodically consensus conferences or guidelines committees, or different types of thinking around these issues. Diffuse axonal injury is a concern as well. And I didn't mention this because it's non-operative, but diffuse axonal injury is something we see, again, high velocity trauma. So motor vehicle accidents, motorcycle accidents are another, kind of part of the history that should, make your ears perk up. But oftentimes we see changes in white matter, whether it's, small punctate hemorrhages. And frankly, there are situations where MRI doesn't necessarily pick up diffuse axonal injury reliably. And so in part, it may be a clinical diagnosis based upon a patient's poor neurologic exam, and also the absence of a clear structural reason for the poor neurologic exam. But getting back to the Milan Consensus Conference, I think what was interesting is that, the idea of when a patient should be monitored and who would be an appropriate candidate was somewhat broadened. The idea that if patients are, even after a surgery, would they be appropriate for monitoring? Some folks feel yes. Some folks say, well, they've had their decompressive craniectomy. It may not necessarily be valuable information. Diffuse axonal injury, again, something we didn't think was appropriate for monitoring, perhaps, and there's some who argue that that is a appropriate indication for monitoring. I just mentioned that because there is variability, and I would say some disagreement in terms of what the ideal candidate for a monitor could and should be. So this continues to evolve. Now, there's also some kind of practice-based, I would say, issues. Excuse me. And I would say one thing I remember from being a student on the wards is it's always difficult because there's clinical practice that's often institutional, the way an institution has functioned. There's practice based on, there's practice based on guidelines, things that are in the literature that you can access during your training. And then there's other things that folks pick up, either due to the medical legal environment in their area, or just kind of how they think practice should be. So it can often be very confusing because you're told, oh, you always have to do this. Then you go to another site and, oh, you always have to do this. And those two things are in complete contradiction. So I bring up these points only to say that I think if you're asked, when should I put in a monitor? And do you think monitoring is appropriate for this patient? You're assessing someone on the floor. I think the goal and the idea is you're being able to convey that you understand that there is some variability. Guidelines such as the Brain Trauma Foundation exist and can maybe help guide your practice, but they aren't necessarily the firm and fast rules for what you will see when you're on the wards. And the other example too is that, if you have a trauma patient taken urgently to the operating room for diffuse injuries, whether it's blood in the abdomen, a big hip fracture, something like that, and there's not a great neurologic assessment. Unclear if the patient's been sedated, they had a breathing tube placed in the field, unclear how much of that's medication related. There is a role for monitoring when you have a patient like this that you're concerned about, but needs other cares. Now, what's interesting too is when we think about intracranial monitoring and the parameters, we talk about elevations above 20 or 22 that are persistent, lasting more than 2 minutes. We are concerned and would administer hyperosmolar therapy, whether it's mannitol, hypertonic saline, or a combination thereof. Intractable ICP elevations, there's a role for surgery. If the patient has just diffuse brain swelling, horribly elevated ICPs, you've failed all the non-operative management strategies, whether it's hyperosmolar therapy, obviously head of the bed positioning, a short-term hyperventilation. You've tried, even phenobarb coma to try to relax and relieve as much compression and swelling, as possible. There's a role for decompressive craniectomy. Now, again, I would say that after a craniotomy, when an ICP monitor may be used, may be associated with other factors. If there's any concerns about brain swelling at the time of surgery, whether a patient is hypoxic or has any issues with hypotension, some would suggest an ICP monitor placed intraoperatively or immediately postoperatively would be helpful. And that's with a craniotomy or even a craniectomy. But again, I think the last point here is still an area of controversy in terms of monitoring in the setting of patients without a bone flap. So just understand that your local environment may have a very strong dogma in terms of how they approach these patients, and they might say, this is it, and this is the way you should be doing it. There is, in the broader community, a little bit of variability and certainly some controversy in terms of what the best approach would be. I'll just kind of briefly talk about this and really skip over this, but when we think about monitoring patients with traumatic brain injuries, imaging is a workhorse. Invasive monitoring, we briefly touched on. There's kind of, I think of it in 2 buckets: external ventricular drainage, which can both be therapeutic and diagnostic in terms of measuring ICP. You can also use monitors of different flavors, and there's always new monitors coming onto the market. But the idea being intraparenchymal, fiber optic monitors, et cetera, strain gauge monitors. They're easier to insert. You can do these at the bedside. You're not aiming for the ventricle, you're just aiming for the superficial parenchyma. And I would say the biggest disadvantage with these monitors is they often need a replacement within several days. Again, subjecting the patient to another procedure, et cetera. And they're not therapeutic. So CSF, external ventricular drainage, can often provide you both those avenues of both diagnostic and therapeutic information. So in terms of which monitor to use, a lot of parameters guide our decision-making, whether it's the underlying etiology, there's coagulopathy, and if the patient has hydrocephalus. And we've talked about non-invasive monitoring, I think not as much in neurosurgery, unfortunately, more perhaps in other realms of trauma, but it's becoming more frequent to think about other ways. So for instance, optic nerve sheath diameter, even transcranial Dopplers can be used, and it gives us just more tools in our toolbox if we're trying to work up a trauma patient. So I just mentioned this, there's a great paper in JAMA Ophtho, I think, from a few years ago that talks about optic nerve sheath diameter. Again, something on the wards if you're being asked something to mention, because it is an interesting non-invasive way of maybe getting a gestalt in terms of ICP elevations. So I think we've talked about this just briefly, but again, the dogma varies depending on the institution you're at. In general, 20 millimeters from 2 or more minutes, elevated ICP warrants intervention. We mentioned many strategies to address. And hypothermia, certainly there's been studies that suggest it has adverse impact. Others, studies and centers are still evaluating the role hypothermia might play. So again, an area that I would say is still being explored But folks do have very strong opinions as to whether or not there's a role for hypothermia going forward. So in terms of outcomes, I guess the question is, with all this monitoring, are we actually moving the needle in terms of helping patients? There's been some literature to suggest that just monitoring, so not necessarily drainage, but just having even an intraparenchymal monitor may actually help with improved outcome. I think it's a little bit questionable in terms of, does that mean that that patient seemed more salvageable from the get-go, and that's why a monitor was placed? There's all those sorts of confounding variables that I think raise some doubts as to, yes, this is promising, but are we just patting ourselves on the back, whereas the underlying issue that the patient had really guided their ultimate outcome? Certainly, ICP monitors can improve efficiency of care, meaning we have this invasive method of understanding pressures. And if a family's, thinking about withdrawal or thinking about moving forward to an LTAC or something like that, it may actually help because it provides us additional information to guide those discussions. So I think in general, any of the procedures we do have complications, whether it's hemorrhage, placement position, if it's a monitor, reliance on the monitor and adjunct beyond the exam, interpretation and troubleshooting. And this, of course, has to do with monitoring. Complications related to any of the decompressive hemicraniectomies we talked about, obviously reaccumulation of hemorrhage, bleeding, infection. All of these things can play a role, especially as patients are often found down, unclear past medical history, and we don't know what other systemic complications they may have.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.